Okay.
Is it supposed to be red?
Yeah, I think so. I hope so.
I've seen them blue before.
Yeah, it's the memory card's full, so it's not actually recording it on the card. Just I hope that's it. Okay, so let's talk with skin care. As we work through the questions in the book, there's a lot of questions over this skin care thing. Okay, we have to keep in mind it's difficult. We don't want to focus solely on the practice questions, okay, because they're going to be different. We have to more or less learn more of the content. So, skin care. When we talk about you guys sitting in these chairs for hours at a time, all right, you need to move. Okay, you already know that through life. You sit in that hard plastic chair for a period of time, and your body signals you to move. You know, you got to move your butt around in those chairs. If you don't, if you sit there and you don't move, then you're going to develop a pressure sore. Okay. Frank back there in that backboard, he would develop a pressure sore. They've done a lot of study, and we'll do this next 6 weeks in trauma. We'll talk about backboard and mobilization, and people who are on a backboard for a long period of time, they start developing pressure sores. That's why when you see this in the hospital, they get those patients off those backboards relatively quick so they don't develop pressure sores. You have the ability to move, so in the hospital or the nursing home, they may not have the ability to move. That's why you have to turn them to keep from having these pressure sores. There's a whole field of medicine, and I'm sure it has a more glamorous name, but wound care, that they go into and they manage these wounds from a doctor to nurses and techs. I don't really see why anybody would go into that, because it's super nasty, and they smell really bad, and visually you'll never eat pudding again if you go into wound care. But anyhow, it is a vital part of your job as a tech to keep in mind that these patients need to be turned. Okay, anytime in the book that you see something in time, like 2 hours, so this patient requires moving, reposition every 2 hours to minimize the risk of these pressure ulcers or pressure sores. Okay, they do make specialized mattresses and beds that help with this, but remember, 2 hours. Every time you want to move that patient, they need to be moved for 2 hours. Okay, and it's preventing the breakdown of the skin. You want to keep the skin dry, okay, and clean. Okay, so if the patient's incontinent, you don't. For one, it's just poor form to leave a patient there. They can't move in their own urine, right? Come on. You know, I mean, just think about it. You don't want to sit around in your own pee, so don't let these patients sit around. They need to be cleaned. They can't do it themselves, so trust me, they would. All right. There's a few people in life that would want someone else to do completely 100% of their functions, but there's not too many. Okay, so if the patients are able, trust me, they would want to clean themselves up. But make sure that you use the powder or the lotions, depending on what the hospital requires or what the type of wound requires, okay? But you just want to look for breakdown. And down here, sort of, here you see, observe patients for skin breakdown. So when you go in and you're taking care of the patient, maybe you're cleaning them or you're attending to their needs, you look for that bony prominences. How would you pronounce that word? Prominences. Anyway, the bony parts of the body, the sacrum, the heels, elbows, these things, hips, back, head. Okay, they're more likely because that's where the pressure is. Okay, and then they break down into different stages. Stage 1 is just where it begins to redness. You have sort of a redness there. It doesn't, the color, you move the patient, it doesn't like a capillary refill. It stays sort of whitish pale. It doesn't refill. So that's stage 1. Stage 2 looks like a blister. Okay. 3 is a loss of where the tissue is visible. Okay. And then stage 4 looks like a crater. So keep that in mind as you go through. What these will do is essentially these type of questions are going to be, you go into the room and you move a patient and you observe this, what do you do? Okay? And again, the answer choice is simple. You would inform the nurse, right? So you look for the dryness, you apply the lotion. Keep in mind the vocabulary word. What's that? That one in bold there?
Maceration.
Maceration, yeah. Breaking down the skin. So anyway, you just a lot of these you just look at word recognition and you know, hey, that's a breakdown in the skin, okay? But very important, probably test wise, is to move the patient every 2 hours. Okay? And observe these. On the next page, page 30, you'll see the different positions. That is important in the sense that like a Fowler's position, a semi-Fowler's position for feeding tubes and suctioning, supine. We know those different types. There's a couple new ones in there like Sims. Okay, laying with one knee up and just relieving pressure off the hips. Okay, this is the way most people sleep. They sleep on their side. They sleep and they draw a leg up. You know, it just feels better. And there's another one that you'll see. And it begins with an L, but you'll see it on the practice test questions. Lip or something. Anyway, you know, yada yada. It's a birthing position. It's where the knees are drawn up. So when mom is giving birth, it's the knees draw up. Okay, you see that word in there and you go, huh, what's that? And then if you do your proper review of the questions, you say, oh yeah, that's a birthing position. Okay. So be familiar with those. We're familiar with most of them. We haven't really talked about Sims. But there's these different positions. The next compression devices that it talks about, and this is to prevent clots or thrombus, right? A thrombus is a clot. An embolus is ones that travel, right? If we had to be a clot, we'd want to be an embolus, right? We'd want to travel. We just wouldn't want to sit there in one place. These compression devices, okay, you'll see these in the SICU. These are put on patients that are in bed for a long period of time. Anyway, they inflate and deflate, and they sort of help blood flow to prevent these, to prevent clots. Okay, they promote blood flow in the legs. If you get a chance, go over there and just look at them. Your job is not to set it; it is to put it on, and then the nurses will set the flow, set the timing on them. Okay, it's self-explanatory how to put them on. You look at them and it just wraps around their calves, right? It squeezes their calves and releases to do that. There's steps on how to do it, but it's fairly easy to do. I mean, you could probably just look at it and say, oh yeah, Velcro, right? Velcro these on, but keep in mind on that's what those are meant to do. Okay, so when you see that, TED hoses are the same, except a TED hose is just like a big pair of socks. Try this at home if you want. It's probably good practice. Up on the medical floors, you might be able to help put TED hoses on. I don't know, you know, but it's literally a pair of socks. Okay, and what I want you to try at home is to put socks on somebody else. It's more difficult than you think. Okay? That's why when you were little and your parents were trying to put your socks on, they may have got frustrated. They're sitting there going, oh my word, why is this so hard? Because it's harder than you think. You have to roll the sock down and then ease it on. And remember these TED hoses, and they have a bigger name, I think. Thrombolytic something. Deterrent device or something like that. You know why we call it TED hose, right? So you put this TED hose on, and there's these big pair of socks, and they help promote blood flow to the lower extremities. When I started working in the ER a while back, I don't do that anymore, I just play golf now. But when I was working in the ER, I noticed, man, my feet would hurt. They would hurt, you know. And I have good shoes on, walking shoes and everything. You're essentially on your feet for 12 hours. You know, so one of the nurses goes, well, why don't you try wearing TED hoses? I'm like, oh, okay, sure, why not? So I did for about 30 minutes. Then my feet went numb. Okay, it's like, nope, these are too tight. Way too tight. But I have noticed that at times that, you know, we have different, I don't know if you have different socks, but I have different socks that sort of fit tighter up on the calves. And when I wear those, not like TED hoses, but these tighter socks, they feel good because it does help with blood flow. But those TED hoses are really tight. Down here, remove the sleeves at once per shift. Check the skin and circulation. So put in a little asterisk beside that. That's an excellent test question. How often do you remove the TED hoses? You know, and hold your breath when you remove them. I bet it's going to smell. You get that dirty feet smell with that. Anyhow, other things that you might do, respiratory care, deep breathing. Remember we talked about this, coughing and deep breathing helps prevent respiratory complications. We went through that one question, right? On there. You turn them side to side, you have them to cough and take deep breaths. And again, we're back to this time thing. Every 1 to 2 hours while they're awake, you would go by and make sure that they given these coughing exercises. And then that was a question on the review questions, and also the patients squint their incisions by holding a pillow against it. So if they've had abdominal surgery, they would place a pillow there, sort of squint that as they're doing coughing exercises to keep that incision from expanding. Okay, and that would hurt. Okay, so this would make them feel better to hold that pillow on there. Both of those were actually test questions. Okay, so you do as you're rounding. Use that word as you're going on your rounds. You may be delegated to say, okay, patient 205. Every 2 hours, I want you to go by there and do these coughing exercises with them. It's sort of that type of thing. And they'll want to hold a pillow on there. This spirometry, I had to say it by phonics. Spy like a spy, like James Bond. Tree. So spirometry, okay, it's a deal where you see the picture of it in the book where it has this it's a little plastic thing. The patient actually inhales into it. Okay, I think I told you different the other day.
Yeah, you said exhale.
Exhale. Yeah, it's inhale. Nobody stop me.
I tried to.
Yeah, just let me go down the wrong path. But actually you inhale into the device, and it tests how well the lungs are working. It opens up the airways to create more of a pathway for fluids. It prevents fluid buildup, okay, mucus buildup. So they take a deep breath in and they inhale into the device, and then as they inhale into the device, it there's a little ball in there that you want to make it raise up. Okay, but that's what it does. I think I have a picture of it somewhere. Maybe, let me. Don't have a seizure. Okay, so stage 1, 2, see how that looks like blisters? 4, that would be a crater. Okay. 15. Yeah. Here's these subsequential devices. These where it squeezes. These will compress and release at a certain time that you set on there. And these are the TED hoses. They look like big socks, but they have little ends to them, so you can check perfusion. You can check capillary refill on those. Okay, and then this is the spirometry. Okay, you have a little spirometer. Spirometry is the process. Spirometer
is the actual.
That's right. And then so you inhale in here, and then there's a little bubble, and it gives you numbers here as they are able to. And this is how you can gauge. You need a number so you can gauge to see if they're getting better, right? So it gives you a value here, and the little indicator goes up. So this would be something that respiratory would come around and do in the hospital setting, right? Something that you might do as well. While we're here, there have been questions on, hey, you know, you're doing ins and outs and they have yellow poo. What do you do? All right. So you inform the nurse, okay? Everybody good with spirometry? My new word of the day. Every 2 hours, repeat every 1 to 2 hours while awake. So I think that the question was 2 hours, right? So keep that in mind. The next thing goes into first aid and CPR. There was a lot of questions on that. What do you do? Okay, so if you have a patient in cardiac arrest, what do? You go in there and Uncle Bob is not with the living anymore. What do? Start CPR. Then what do? Call for help. Say, we have a code. Start CPR. Hit the code button. Wherever you are, but you would start CPR. Okay? There was a question in there that you went to the room and you noticed the patient was in VTAC. Okay? From the question, you can pull out of there that it was VTAC without a pulse because the patient was unresponsive. What do? Start CPR, right? It did say one of the answer choices was go get the AED. But why was that incorrect?
Because you said he's unconscious, he's not pulseless.
Yep. But they were in cardiac arrest. But VTAC is a shockable rhythm, right? They need to have the defibrillator. I don't want to confuse you because you would start CPR. Okay? So if someone dropped dead out in the hall and the AED is like right there, you would still start CPR, right? Yeah. You would start CPR if the patient is pulseless. So you would start CPR and then go get the AED. So in this test question, in this line of thinking, start CPR, right? Okay? First aid, bleeding. Obviously, everybody knows, hey, you stop bleeding by direct pressure, right? So if you go in there and Granny has pulled out their IV and they're bleeding everywhere, then put on some gloves, get some 4x4s and hold direct pressure on there, right? And then tell the nurse. Right? Let the nurse know that they're bleeding. They may have a nosebleed, which is a special weird word somewhere in here. Oh, epistaxis. EPI, epi. Staxis, S-T-A-X-I-S. why in the world they would come up with that word instead of just saying they have a nosebleed, I don't know. But
We have it for everything.
they have a nosebleed, so it goes in there, lean them forward, pressure on the bridge of the nose, about 10-15 minutes. Okay, if there's notify the nurse they have a nosebleed. You can put some 4x4s up the nose, right? Okay. If you're in an emergency department and they have a nosebleed, they have these little clamps like this, because the bridge of the nose is where it's bleeding from. Okay, that's why you put pressure here and lean them forward. Never lean their head back, right? They don't swallow that blood, and then they'll be vomiting that blood. Okay, the stomach doesn't like it. So, or you could just, if you have these, then you could put this little nose clamp on there. Okay, and they have what's called a rhino plug in the emergency department, and it looks like a tampon, and you just put it up the nose, and then it absorbs the blood, and then it puts pressure on where the bleed is, and then it stops the bleeding. Okay, it's super nasty when you take it out because it has all this coagulated blood on it, and a lot of times that gets really stringy. So when you pull it out, you get this big old stringy blood clot as you pull it out the nose. It's cool to look at once, you know. Otherwise, you're just gonna go, "Wow, that's nasty." Then it gets into other emergency choking. This was one of the questions on the review. You know, if the patient's in the cafeteria and they're using the universal signs for choking, so they're like come up to you like this, right? Because you're in scrubs and you go like this. This is the universal sign of choking. What do you do first?
Are you choking?
Yes, I know it sounds crazy, but why do you ask them, "Are you okay?"
Because if
Are
they
you
can
choking?
talk, then that
Yeah.
doesn't mean it's fully obstructed.
Right.
And
If
if
they
they
can
can't-
speak to you, then they're not choking. Okay. They still may have something back there, but it's not fully obstructed. But if they're coming up and they can't speak, then they have a full body airway obstruction. So you need to do the Heimlich maneuver on them, right? Get behind them, find the belly button, xiphoid process, go in the middle, and do these abdominal thrusts. Okay, for the Heimlich. And that is until the object is expelled. If the patient becomes unconscious, then what do you do? Yes, you start CPR. You start chest compressions. Okay, and the chest compressions are going to act as the abdominal thrust, and then you're sort of in a healthcare scenario anyway. But then you would call for help, right? Yeah, I mean, if the patient becomes unconscious, you wouldn't necessarily hit the panic button if you sit there doing the Heimlich. Don't worry, everybody in the world is doing look at you. Some will just what are they doing? That's a weird way to hug, you know, and continue to eat. But if the object comes out, then there's not really an emergency, you know. They may need to be evaluated, you know, a little bit, listen for lung sounds, make sure that they're moving good air, but that's about it. Seizures. We talked about seizures, shock, and syncope or fainting, right? Seizures, don't restrain them. Remember that, okay? It's been years and years since we've taught to put something in their mouth, okay? Your grandmother, your great-grandmother may say, put a spoon in there, put a stick in there, right? But we don't put anything in their mouth, okay? If they're having a seizure in the cafeteria, remove the tables around, protect them, hold their head so they don't hurt their head, don't restrain their head, just sort of hold their head, and then you turn them to their side because they're going to put off a lot of mucus, so they don't aspirate. Turn them over to their side, let them seize, and that way the fluid can drain out. Okay, and that's proper care of a seizure. If you have suctioning, then if you're in an area where they're suctioning, then you want to prepare the suctioning, right? Shock, keep them warm. Very first sign of impending shock is what?
Is it, well, no, the
It's been a while since we talked about this.
The temperature?
No, not temperature. Huh?
Blood pressure?
Pressure, blood pressure is
Isn't
a
that
late
later?
sign of shock.
Oh, okay. That's what I was saying, I thought that was later.
Pulse.
What kind of pulse? Rapid pulse. Sustained tachycardia, okay, or sustained tachycardia is one of the first signs of shock. Actually, a little anxiety and restlessness is the first sign, okay? But first, that would almost be a symptom, right? You can't really see that, but a sign would be a tachycardia, all right? So if you look at there, they have this blank stare, cold clammy skin, right? Because they get cold clammy skin because the body's doing that auto regulation. It's pulling blood away from the skin for the vital organs, okay? But you'll see a tachycardia first. But call for help, lay the patient down. It says in your book to position the head below the body, so to put them in a Trendelenburg, right? Remember that word? Trendelenburg position where the feet are higher than the head. They don't really teach that anymore, and they haven't taught that for years, but healthcare facilities still use it, okay? When you place a patient in Trendelenburg, it reduces venous return, but it does raise the blood pressure. But for our purposes, right, when in Rome, because we live in bookland, you want to position them lower than the head lower than the body. So you would put them in a Trendelenburg according to this. Okay? Good? Someone faints, syncope, right? Elevate their legs, lay them supine, elevate their legs. Okay? Or have them sit. If they're conscious, have them sit, place their head between their knees. So it helps sort of return blood flow back to normal, stabilizes the blood pressure a little bit. Okay. CPR we just talked about, right? So look at them. Are you okay? The patient becomes unresponsive. Like you're sitting there, you're taking care of them, and they become unresponsive. Ask them if they're okay. Right? Are you okay? If not, CAB. Right? They're unresponsive. Check a pulse. No pulse. Start CPR. Hopefully the test is following the American Heart Association guidelines, okay? Everybody else does, so.
It is.
Okay, good. And then really, overall, I mean, a gazillion questions in here where you report changes in the patient's condition. Remember, you're the front line person, so you report changes in the conditions, okay? Especially no pulse. Hey, I'm on my break. I don't care if you have a pulse. No breathing, and then you get in to immediately notify the nurse. There's a list there: cyanosis, shortness of breath, difficulty breathing, falls, changes in level of consciousness, choking, right? Really bad pain. And then there's a list of not necessarily immediately, because you'll see both of these questions on what do you do. So these are familiar to be. I mean, these are good to be familiar with. So these are bad things. This is what I would immediately notify the nurse on. Okay, so I would remember those, and then everything else is not. I don't have to drop what I'm doing and go tell the nurse. There are questions on there where they want you to make that choice, right? And of course, if they're threatening suicide, then that would obviously immediately report that. Everybody good?
Yes, sir.
Questions? All right. I don't think we have too much time. Bodily functions, ins and outs. This is where you get this formula. 1 ounce of fluid equals 30 milliliters. So there have been questions on there that when it's measured in, you know, you have 8 ounces of pudding, I think it was, or that's a lot of pudding. But you have pudding would be a liquid. Okay, it asks you, which one of these would be considered a liquid? So like pudding would be considered a liquid. Okay, then you just measure ins and outs. So there was one question on there about where you had to convert ounces to mLs, but if you can remember that, that'd be great. Also, there was a thing on there, the patient has to have a bowel movement in 3 days. That was a question, you know. To me, 3 days is a long time to go without BM, okay? Nobody wants to talk about poo, but I'm telling you, you should poo every day, right? So, if I don't poo once a day, then I have questions. I'm like, I need to change. What am I eating? You know, that's not letting me go to the bathroom. Anyhow, 3 days. Again, anything that's measured in time, you want to take a note of. So 3 days. Okay. Edema, swelling. There was questions on there. Which one do you immediately notify the nurse for? Like, you know, they'll give you some pulse rate and blood pressures and then edema. I think we went over that question where it was the patient couldn't help. They needed help moving their legs or they had edema. I missed it. It was the edema. Then it gives the definitions for pitting edema. I don't know if I would really remember a pitting when you push it in the little pit there, right? And then it gives the definitions for +1, +2, +3 in millimeters. So +1 is 4 millimeters, +2 is 6, +3 is 8. Okay, no. +3 is 6. +2 is 1, +4 is +2. 6 millimeters is +3, and then 8 millimeters is +4. Probably nothing. I wouldn't necessarily commit that to memory. Just note what pitting edema is. Like they have edema and you push in, the pit goes so deep, you know. Because that would be something that you would notify the nurse as well. We're familiar with pain scale. We've been using that scale 1 to 10. Small children, they have the happy face and the sad face that they show. There's a name for it. I can't remember off the cuff. But there's one, you know, if you have a child, they don't really understand. They may not understand 1 to 10, but they look, which one are you? Are you this happy face? Or are you this frowny face? Or this sad face? And then that gives you a number to go off of. But for adults, it's 1 to 10. There's some things where you can see nonverbal signs as in pain. The patient can be tachycardic in pain. That's one reason that you know that they're in pain, that they're increased pulse rate. Okay. Blood pressure is a late change all the time because blood pressure is the last one to drop. Remember, rate, rhythm, pressure. Pressure is the last to drop because the body compensates for it. So we're already familiar with that 1 to 10 scale. Using that, we need a number. Why do we need the number?
To see if they improve.
Right. Exactly, and as a baseline, right? Without a baseline, we don't know. That's why we take baseline vital signs, so we have a baseline, something to go off of. Okay. Wound infection, you'll see this, and these will be, which one do you report to the nurse? You have drainage, you have wounds that drain. Exudate is a pooling of it. It's just a thing again to know the vocabulary because it's going to say which one of these wounds. Purulent contains pus, okay, and then biggest thing here is nurse immediately, okay? So you see these different things. Part of your function as a PCT is to go in and change the dressings. We talked about that the other day, right? You change the dressings. If you see something that looks really strange, if you take that dressing off and it's really draining excessively, or it smells, it has a death smell to it. Common sense, right? Common sense would say, I better go tell somebody about that. So you'd go tell the nurse there as well, because you're on the front lines. When you start dealing with patient specimens, like stool and urine and sputum, this is why you continue in school to get higher education, so you don't have to collect stool samples or sputum samples or urine samples, okay? But there's a list in there, on stool. If report to the nurse immediately. Diarrhea, liquid stool. You have fruity pebbles. Where you guys eat fruity pebbles?
Yes.
It's pebble-like stool is constipation. So you can remember that by your fruity pebbles. So if you look down in the toilet, or you're looking at the stool, the patient gets ins and outs, right? And you see fruity pebbles, then you need to tell the nurse, hey, the patient's constipated, right? The patient will probably complain of being constipated, okay? No stool for 3 days unless NPO, that's a given test question. Blood in the stool, you want to tell the nurse right away that there's blood in the stool. There can be trace blood in the stool, and it may just be a hemorrhoid. If the patient is constipated, and they're having to bear down really hard to have their bowel movement, then they can sort of blow a hemorrhoid in there, and it just be trace blood, but you would still need to report that to the nurse. Gross blood, a lot of blood, definitely, obviously, same way with the urine. Tarry looking stool, dark red blood, or black, it means that's digested blood, so that's been there. That's a sign of a GI bleed. Trust me, when you have blood in the stool, you're going to know it before you see it. That's number 2 on Randy's worst smells in the world is GI bleed. You're going to know that smell. Once you smell it, you go, yeah, that's blood. And then this would really gross me out by having pus in it. You're sitting there going, Again, it's just part of the. Don't worry, even as a medical student, you have to do these observations, and you're going, man, I'll be glad I'm a doctor, so I don't have to look at people's poo anymore. But sputum, the same way. That's probably what grossed me out the most. I just can't. I can't deal with spit, snot. But again, you would look at, is it discolored? Is it green? Is it yellow? Are they spitting up? What's in it? These different things, red or brown. You report that to the nurse as well. Urine, it has a special or new descriptor here to it. Pale straw color. You know what straw looks like? Okay, and that's in the test question. I was looking at that, that's like a straw color. When do they start using that? But normally pale straw color, or yellow amber. So you have to know the norms before you can know the abnormal, right? What's normal to abnormal. So urine should be almost clear, okay, if they're properly hydrated. But then again, there's these things, hey, and report that to the nurse. Color, blood, visible blood in it, a lot of urination, okay, polyuria, right? It's a sign of what? Patient's polyuria, the 3 P's of what? diabetes, 3 P's of diabetes, DKA, throwing off polyuria, okay? Real concentrated urine, which real dark in color. It's just a problem with probably you're dehydrated. You usually don't see diluted urine too much because unless they just drink an excessive amount of water, they can dilute their urine. And then no urine is hugely important. No urine output means the kidneys aren't working properly, okay? Or there may be an obstruction somewhere. But you would report these to the nurse as well, okay? Patient starts throwing up, report it to the nurse, right? Make sure that they're sitting up, that they don't aspirate. And same thing, report blood in there. Coffee ground emesis. What's coffee ground emesis look like? Coffee grounds, right? Sort of dark brown in nature. It can be liquid. You know, they start throwing up stuff that looks like coffee.
That's something.
Then that's a problem. That's usually blood in there. Okay, partially digested blood. And then so emesis that you would report. Other things like critical lab values. The lab itself, so they draw a lab, and let's say there's a potassium, critical potassium, okay? The lab is going to contact the nurse directly. It's not your responsibility to interpret these, but the most common one, like it says here in your book, is the glucometer. So that you're sent on a task to go do a D-stick, and you come back and it's 500, right? What are you going to do?
Report it to the nurse.
Report to the nurse, right? Yeah. So that would be the most common. The lab, like blood draws and different things, different labs, the lab is going to call the nurse. Not your responsibility to know that, oh, that's a high potassium. Okay. So, but the glucometer necessarily is. There's a list over here on page 40 of different glucose levels. Just remember the normal. You know, what's that word postpran? After you eat. Well, how do you say it?
Postprandial.
Yeah. Huh?
Postprandial.
Yeah.
That's how we say it.
Good enough. And then, so that's after you eat. Again, there's a time there, right? 2 hours after you eat. So again, anything with time in it, highlight that. 2 hours after you eat. So you go draw this lab 2 hours after the patient eat. You go in the room and you see a food tray in there. You'd ask the patient if they've eaten within the last 2 hours, right? If they've eaten in the last 2 hours, then you would inform the nurse, hey, patient, they've been eating for the last 2 hours, right? Be familiar with those lab values. 74 to 106, 70 to 120, right? Just, it's a range. Be familiar with just the different ranges. The same way with vital signs. I missed the question over here because I really didn't think about it. You know, I told you the other day, always report the fever, right? And I missed the question because it says it had a 99.1 temperature. It's like, okay, boom, report the fever. Wrong. Because oral temperature is from 97.6 to 99.6. Okay, that's normal. I wasn't really aware of that, and I just went off that cookbook thing where I report that to the nurse, so I hit the temperature. So be aware of the different, I would say just the oral ranges, okay? Rectal 99.6, okay? Heart rate, we know 60 to 100, respiratory 12 to 20, and then the blood pressures. So to be familiar, pyrexia, right? Pyrex, like the bowl you have to eat out of, Pyrex bowl, temperature, right? Hyperpyrexia. So when you have fever, you're going to have chills and everything. Okay, so hot, cold liquids can affect the oral temperature, give you bad results. So I think you already know that from life. But be familiar with the rates, heart rates over on the other page, respiratory rates, apical pulse. So if you have a irregular heart rate, it's good to take a apical pulse where you hear it, you listen to it. It's no, because there was a question the other day, I just took a wild guess at it. It asked for the intercostal space where you would take the apical pulse. And I literally was here going 1, 2, 3, 4, 5, 6, 7. I think it's 7. And I did that, right? So you would count that for a full minute where you listen at it. In these things we talked about already, a thready pulse or a weak pulse, a bounding pulse, okay, a very strong pulse. Just know that. And we know a weak pulse is a +1, a bounding pulse is a +3, then a normal pulse, I'll get it out. Normal pulse is a +2. Okay, but they don't go into that detail. And it gives some different ranges of newborns. I would just be familiar with that, okay, in the vocabulary. Almost done. I feel the pages going away. Blood pressures, manual pressures. Hopefully there's no questions about manual blood pressures, right? We've taken enough manual blood pressures. I do like the way that they do an auscultated blood pressure here. I'll probably start teaching it this way, is they take the radial pulse, they feel the radial pulse, they pump it up until the radial pulse is gone, right? Now we want a palpated pulse, once that radial pulse is gone, then we release the pressure until the pulse came back, right? Once the pulse came back, then that would be the palpated pressure. But what this is saying, to get an auscultated pressure, you feel that, you pump the cuff up. It says in here that no longer can hear the pulsations, but you can't hear the pulsations till you start pumping it up. Okay, it's better just to feel that. So when you pump it up, the radial pulse goes away. Okay, and then add 30 millimeters of mercury to that, and then auscultate the pulse. Does that make sense to everybody? It's a little bit different system, but it keeps you from having to do a palpated pulse every time. We know the first sound is the systolic, the second sound or the last sound is the diastolic. Pulse oximetry, shouldn't be any questions. Cold hands, fingernail polish will affect the pulse oximetry. Keep in mind, people with emphysema and different respiratory problems are going to have maybe a lower pulse ox. Okay, but that's something that we would report. I think the question was below 90%, but remember this is a range thing. Anything below 95 is abnormal. Capillary refill less than what? 2 seconds. So you squeeze the finger, less than 2 seconds, and so that sort of goes through the vital signs: temperature, pulse, blood pressure, respiratory rate. The next part is really important. It says 5 rights of delegation. Not only are there a lot of questions about it, but it's important that you know, to keep you out of trouble, that you have a scope of practice, and you have to stay within that scope of practice. Okay, when you're delegated, you want to make sure that you're performing the right job. Okay, and does this fit in my scope of practice? So does this task that I have, does it fit within the scope of practice, or do I have the qualifications to do it? Right? The right circumstances, is it safe? Do I have the equipment? Is the patient stable enough for me to perform this? Is everything right? identifiers, make sure that you're doing that on the right patient, okay? That has happened to me before. I just dropped the ball. There's two people in the same room. They were relatives, and I did a procedure on the wrong one. Okay, oops. Bad, man, bad. Okay, make sure you have the right person, the right direction. I get this confused because I was thinking medical direction, but right direction, okay? I think a better word for that is instruction, but do I have the proper instructions? Do I have enough information needed? Okay, and do I understand what is expected? That's always good to know, right? So if you're told to do something, okay, do you have the proper amount of instruction? Give you a little non-medical story about that. My youngest son, I tell him, take out the trash. Without fail, he'd go in there and take out the trash. What would he not do to complete the task that I thought he should be doing? What do you think he didn't do?
Put it in a bag and put it away.
Huh?
Put it in a bag and throw it away.
No,
Did
it
he
was
just
already in
like-
the bag, yeah.
Do you just put it outside just there?
No, he put it in the trash can.
You didn't put another bag in the trash? You
Huh?
didn't put another bag in the trash can?
Very good. He didn't put another bag in the trash
I
can.
do that.
Yeah, yeah. And I was like, boy, what's wrong with you? But I wasn't
Take
giving
out the trash.
I wasn't giving him the right instructions or the right direction in here, right? I was leaving a part out where what I should have said is, I want you to take out the trash and replace the bag in the trash can. Okay? The trash can liner. And once I cleared that up, very good. Perfect. It's the same way. I want you to, with the dishwasher, you know, put the dirty dishes in the dishwasher away. You have to unload the clean dishes first before you put the dirty dishes back in there. Right? It may seem simple, but you want to make sure that the directions are clear, you know, of what the task is. And then the right supervision, okay? Is there somebody there that can answer questions? And this will come up in a minute, but you follow a certain chain of command. So your chain of command is the nurse that's in your charge, okay? And then after that, if they can't help you, you have the charge nurse, right? And then if they can't help you, have the house supervisor in a hospital setting. Alright, so make sure there's always more nurses and more things to do than there are techs. So you would prioritize what you need to do. Every nurse wants their stuff done right then, okay? So they can get their business done, so they can play on their phones, okay? So, but you have to prioritize what to do. So you work on that, and just understand that there's multiple patients and multiple things to do. That's just part of the experience in life that you get. And then it goes into this Maslow's hierarchy of needs. This is a different. How many of you guys have taken psychology? You might know that this is a different Maslow's little triangle, little pyramid here than the psychology one. But they want the one is physiological. Physiological. But it doesn't have the L. A-L. Physiological. Physiologic. But it just says logic here. But anyway, food, shelter, food, water, sleep, not being cold, right? Security. Make sure that the patient is safe above all things. Okay. they want you to take an interest in there. You know, if you've ever been in the hospital, and you know, hopefully not. The last thing you want is someone that has no interest in you. You're there, you're sick, you're in the hospital. Take interest in your patients, right? Protect their privacy, pay attention. Some people are really concerned about their appearance while they're in the hospital. Okay, I'm not one of them, but you know, they do. And then the last one, they want to recover, so they need help recovering. I don't know how much time over the abundant information in here that I would put into this. Would be one of those things I'd just be familiar with. Okay, I think good test questions or good test taking techniques would be sufficient in answering those types of questions. I mean, a lot of them are just common sense. And then the last thing, hopefully, well, a couple more, not too much. Okay, the last thing is hospice care and postmortem care. Hospice is the care that the patient who they have a fatal illness or they're dying, they go home, they're on hospice care. There's a huge industry on hospice care. Do you guys ever, if you known anybody on hospice before? You know, they just go home to die, you know, and the hospice nurse or the hospice organization comes in and takes care of their palliative needs or their daily needs to make them comfortable. Okay, so obviously postmortem care is different, but hospice, in just a side note, another job that you guys can do as a PCT is home health. That they'll go out and maybe this patient on hospice doesn't have any relatives, and they will send a sitter out there to take care of their needs. Or maybe they're on hospice, but they can't cook, or they can't clean, or they can't do these things. They'll send a PCT out there and pay them, right? It's a job, to take care of that person. And it's, if you like that sort of thing, that's not a bad job. Okay. Coping mechanisms. There's just read through that on the next page. Just as far as familiar with it, okay. And then understand it goes in here, this stages of grief. We talked about that the first part of school. There was questions on there about the stages of grief, okay. So restudy that, just be familiar with those. One, you know, I think the question was, I just want to see my son, my daughter graduate college or whatever before I die. You have a patient on hospice, and they want to see something before they die. You know, they haven't accepted that yet, so they're trying to bargain their way out of it, or denial. I just can't believe this is happening, type thing. Remember, we want to get to the acceptance level. I must be hypoglycemic. I can't hardly talk.
Yeah, you must be.
Or I'm having a stroke. Which one? No?
Hello.
Hypoglycemic. No dizziness, headache. And then we get into postmortem care in there. It goes through several things that you'd want to do. Essentially, you're sort of cleaning up the body as for the family to put in. The question here was, what do you do? And I missed it because it said put a pillow underneath their head. I'm like, put a pillow under their head for. But you want to place the pillow before they have rigor mortis in there. So you're just getting everything, cleaning up everything, so that it's the patient is more presentable to the family. One thing in here it did say is would allow the patient or the patient's family to participate in the postmortem care, and I've missed that because I'm like, nope, that sounds weird. So I checked something else, and that was correct, that some cultures or some, I don't know, some people, that's part of the ritual, that they want to do that. They want to prepare the body. Okay, so just be aware of that as far as the question, but the answer was there to place a pillow under their head. It's a different, I used the term rigor mortis, okay? The book says livor, 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 mortis, okay? Same as rigor mortis, okay? But be familiar with the two terms. Heat, an excessive heat in the house will affect that, will speed it up. Excessive cold will slow it down, okay? Rigor mortis always shows up in the neck first, so they get a sort of a stiff neck. That's just FYI, okay? But rigor mortis or livor, maybe, Livor mortis, is about 1 to 6 hours, 2 to 4 is the average, and then you get what's called dependent lividity, and this is where the face discolors. Okay, so if the patient dies and they're laying on the side of their face, or they're laying supine and they're in bed, right? Dependent lividity can form, and that's just pooling of blood. So you'll see some discoloration, wherever they're laying. So if they're laying on their back, you're going to see dependent lividity in their back here, or if they're laying down on their face, you'll see the blood pool on their face. Okay. And so that dependent lividity takes place 20 or 30 minutes. That starts that starts to take place. Okay, so rigor mortis, or that livor, Livor, how would you say that?
I don't even know what it
Mortis,
is.
rigor mortis, stiffening, dependent lividity, pooling of blood. Okay, it says don't. I know you shouldn't laugh at the dead, but it says don't place one hand on top of the other. Right? Can you imagine if you place it? They look so peaceful, right? They look so peaceful. They're laying there, and the family comes in, and they have the tear going, and their hands are on top of each other, and all of a sudden the hand falls off. They go, Granny's going to have a stroke. He's alive, And so put the hands down to the sides where they don't have any movement. Okay. The whole process here, the way the body changes and everything with death, is that when you get death poo, all of the orifices open up. So this is what I'm saying about preparing the body. They're probably going to poo on themselves. They have urine. All the orifices open up. So you have to be sort of ready for that. It goes in here later to shroud the patient. So after the families come in, you would put like make a little burrito with the sheet, wrap them up with the sheet, if that's the policy. Okay. Start talking about putting a tag on their toe, their right toe, everything. I don't know about that necessarily PCT wise. This is something that they would do maybe at the ME's office or something, more towards after the funeral directors or the ME has picked them up. But read through there. Allow the grieving process to take place. Okay. And different people grieve in different ways, so just allow that to take place. Okay. That's hugely important for recovery for the patient's family. Questions? Know the vocabulary in the back of the book. I have a big, huge note here. It says know the vocab in the back of the book, 199. Just flip over there, see what that looks like right quick. Oh, the glossary. Yes. Know all these words, okay, in the glossary, so you know the vocabulary. Like I told you a gazillion times, you can't pass a test if you don't know what it's saying. You don't know the vocabulary words. So make sure that you're aware. Most of these you know, I believe, okay? Some you just have to sort of look over. Good? Questions?